up right now, we will have John Warner, Dr. Noel Kapoor, Harjeet Kaur, Dr. Shafina Premji, Dr. Minal Tripathi, our genomics lab director here at BioAero Company, moderated by Dr. Balraj Singh.
Hello, hello. Seems like you have survived till the afternoon, and it seems everything, all the conversations have been quite interesting. So you're still intrigued, you're still interested, and you're still with us. So that's the important thing. Good, excellent. We like that enthusiasm, and especially after that last presentation. I think Dr. Premji, you basically hit it out of the ground there with that. Okay. So I think this has been a very interesting conversation where we have been talking about precision health and personalized medicine. So obviously we are at that point where a lot of us now understand when we talk about precision health and personalized medicine, what exactly are we talking about? The question becomes, are we actually adopting it into clinical practice or not? And what are some of the things that we can do to make some of these technologies available to the end users, our patients? And so on the panel, we have a very interesting mix of people, starting with Dr. Premji, who has been working in the area of hormonal therapy, and she spoke very well about how some of our patients can benefit or are struggling with some of the issues around that. We have Dr. Anmol Kapoor, who has been an innovator, and he has been at the forefront of various innovations in cardiology. And then we have John, who is actually working on creating those innovative companies and seeking investments into those. We have Dr. Meenal, who is leading our labs for developing the genomics program. And then we are very fortunate to have with us Harjeet Kaur, who has lived through some of these challenges, right? And we talk about a patient at the end of the line who's waiting for these things to be translated into clinical practice. But she's an example of how early diagnosis, early detection can help. And so if the panel is comfortable with me starting with her, and we can probably start with you, Harjeet, and if you could speak a little bit about your experience, especially the stage at which your problem was diagnosed.
So I just wanted to say thank you for having me, and I actually moved to this country in 2018, having dreams of settling down, having a family, having a house, having a good career. And I was just in my early ages, 30s. And after 8 months, I think in 2019, I started having this symptom, which was just high fevers. And we were lucky that we had a family doctor who could actually, address our problems and actually, do the scan, do the tests, blood work and all. But unfortunately, my blood work didn't show any, activity which could lead to cancer diagnosis. But I had these episodes of high fever for almost 3 months. And every time I used to end up going to emergency, I used to be told that, you just have fevers, you don't have any other symptoms, just go home, take Tylenol, take rest. And this episode was, keep on going, and I started having chills, my body started swelling up. And my husband and I, we advocated that if we can, get a reference to a medicine specialist or someone else, and I was referred to medicine specialist at University of Alberta Hospital in Edmonton. And he did the same thing, he did the blood work and nothing was working out. And I had no idea how the health system works over here. So we asked them if we can get the CT scan done, just to know what's happening, because I have this feeling that something is not right. And my husband said that, I'm ready to pay. I'm ready to pay for out of pocket, but can we have a CT scan? But they said, no, we can't do. This is not the way we deal with it. And we just almost gave up because it was almost 1.5 months. I was struggling with all those things. And finally, one day they called and they said, okay, we'll do the CT scan. And they did the CT scan, but they didn't find anything unusual still. But they said that they need to admit me to the hospital to do extensive tests and scans. And I was in hospital from June 2019 mid until September 2019 for 3 months. I was treated as a research patient, honestly. I had endless biopsies, surgeries, all invasive treatments. I was sick and tired of all those things and almost gave up. We both gave up and we were like, let's just go back to India because they are not talking and doing anything else. So one day they came and they said we'll do a skin punch biopsy, which was after so many months, and the diagnosis showed that I had stage 4 subcutaneous panniculitis T-cell lymphoma, which I had no idea about. What is it?
So how far were you out into all of these testings and procedures when you finally actually did end up getting a diagnosis?
So how far I was?
Yeah, like how long did it take you to finally end up getting a diagnosis?
3 months.
3 months.
3 months. I was diagnosed at the age of 32 and I was in hospital for 2.5 months plus 3 months and had a couple of tests and scans. And strange part, when I go to these conferences now, I hear about testings like genomic testing, gene testing, but no one was there to tell me about all those things.
And so, am I correct in assuming that you were not offered any type of genomic testing or epigenomic testing?
No, I had no idea about it. Plus, I was an immigrant. I had no idea how to navigate the healthcare system. There was no education piece out there or any kind of awareness given to me or my family about all those testing. And that's strange because when I talked to you earlier that you said that in 2014 or 15 everything was there, but how come in 2019 I was not even addressed about this thing? And maybe I was young. I think they never thought that I would get, cancer. That's why the diagnosis took delay. But I feel like I regret, if I was early diagnosed, I could have gone through all those things which I'm going right now at this young age. I was thrown into early menopause. I'm having long-term side effects of cancer. I had aggressive treatment. I had stem cell transplant during COVID. But I'm lucky, I'm grateful that I'm here. I'm living my second life. But there are those things which need to be addressed and talked about.
Dr. Kapoor, if I could come to you, I've heard many of these things from you as well, in terms of early diagnosis. And I've heard you talk about way back, I think 2016 or something, when I used to hear you say that I struggle with the system, my heart failure patients, they're struggling, I cannot monitor them on a routine basis. What do you think from an innovation perspective are we lacking, which drove you basically to start developing those in the public sector, in the private sector, sorry?
Well, it's a story from a patient. I was in Orlando attending American Heart Association Congress, and nurse, we used to have a nurse. We ran a Dilwa Foundation funded heart failure clinic, and just to keep them out of the hospital, there's no money from the government at all, ever, till today, in that area. So the goal was we hired LPN because LPN is the bottom of the chain, the cheapest to hire, and in the nursing realms. So let's get LPN, there's only we can afford, and let's empower them, educate them, which system think they're not skill set. And we said, okay, let's prove them wrong. So they think nurse practitioner has to be hired or the really advanced cardiac nurse has to manage the heart failure patients. So we train LPN, and then she was looking after the patient, and the patient, by chance, she called me in Orlando, and she said, Dr. Kapoor, the patient's son is angry, and he's very, very angry. I said, what's going on? He's want to bring this patient to the clinic. And it's charitable clinic. There's no money, nothing happening. And I said, let me talk to the patient. And what's going on? He said, look, he has a bad heart. The heart is not even moving as much. And he needs to do an NT-proBNP, the blood test, and to monitor his medication along the way. And he was drowning in water all the time. And his son had to take him to emergency room or take him to lab to get the blood drawn, and the report will come back. Then he comes back to the clinic. So he has to come to the clinic, order to get the requisition, go back to the lab, get the appointment, get the blood test, come back. It's a torture for him happening. So then he said, Dr. Kapoor, I'm burdened on my son now. He has to take time off from job. He's suffering. His family life is suffering. Just let me go. Let me die.
How unfortunate that is.
Yes. So that's what triggered me, and the whole journey started from there.
Now, you have been on we are listening to Harjeet talk about her ordeals with the early diagnosis part of it and the lack of it, how long it took her, and she still didn't get a genomic test done. In your case, you had patients, and you decided to take the initiative and build an ecosystem that allows that innovation, the development of those novel point-of-care diagnostic technologies. How much support has the public sector provided you in your innovation journey?
None. The public sector is bureaucratic. It's designed to give control to certain people who want to have an empire they have created, and they want to live in powerful positions. They don't want any innovation come in. So the idea, any innovation comes from bottom up. So anyone in this room can give a brilliant idea. Innovation. Innovation is just an idea comes in. You just have to make sure you implement it properly. But usually the people who sit on the top of the system suddenly realize that anyone coming from outside is a bad thing, and let's not touch it. So unfortunately what happened with Harjeet, so that is happening to all the Canadians right now. Look at Albertans are sending their samples overseas. The prostate cancer patients are struggling. They cannot get the prostate cancer testing. Now, we are donating 100 samples for free. And metastatic men who can't afford. So $1 million worth of donation we are doing as a BioArrow. We should not be. We're a company. This is a healthcare system, taxpayers. They pay taxes. So system is not helping them. Breast cancer patients. The AHS data shows on their website how long they're waiting those patients.
But doesn't that help the healthcare system reduce the economic burden?
Well, it does help reduce the economic burden, but they think differently. So what they do is there is a wine glass. So that many people who need the testing, but then they decide somehow, randomly, there's no science, there's no logic, and like a stem of the wine glass, only that many people will get the test. And that's the wrong thing, it's rationing. So we are rationing people's life. And publicly we are saying, we believe in you, we want to save you, every life is worth saving, but political leaders and the bureaucrats in the system, including clinicians in the system, doctors are also in the system too. So we made that system, and then we become a powerful position. We say, look, now I'm going to decide who's going to live and die. And that's wrong.
Dr. Premji, if I could bring you into the discussion, you spoke about some very critical things, and I love your comment about even if you don't have ovaries, you love someone with ovaries. I think that must have echoed across the room very well. You talked about something where you spoke about that early menopause can potentially affect aging. And here we are talking about innovation in the ecosystem and how that innovation can help us to age in a healthy manner and improve longevity. But you are talking about early menopause affecting aging. So if you could reflect on that, and then is there something in the ecosystem that allows us to actually detect that early menopause and have some sort of a mechanism in place so that we can improve the aging and longevity of those people, those women who end up actually having early menopause?
I don't know if this is working. Hello? Can you hear me?
No.
Yeah, mine?
You
Can you hear me? Hello? No? No. Oh, now can you hear me? Yes? Okay. Sorry. Thank you for that question. So when women go into menopause at the natural age of menopause between 45 and 55, that is considered a normal part of our reproductive span. But for women who go into menopause under 45, which we call early menopause, or under 40, which we call premature menopause, this is actually an endocrine deficiency. So estrogen is a lubrication to our blood vessels and has many, many important roles for our bodies. In fact, women who go through menopause early or even in the natural age, they are more likely to develop hypertension, more likely to develop diabetes in that time frame, more likely to develop hyperlipidemia. And patients will come to me and they will say, like, I've never had blood pressure issues, and now why is this happening all of a sudden? And they don't realize what the value of our estrogen is. And so it's important that women and healthcare providers are able to determine and ask patients about their periods, because a lot of patients who come to me, they have actually been diagnosed with menopause in their 30s and early 40s. Nobody addressed it, and now they're 53, and already have osteoporosis, already have diabetes, already have hypertension. So the earlier we recognize it, the better we can get them onto treatment and hormone therapy for prevention of these things. For the average age woman, we don't use hormone therapy for prevention. We're using it for symptomatic relief. But for under women 45, we are using it for prevention. Is there a special test or is there a way for us to determine if a woman's going to go into menopause early? Right now, we don't have that research. That would be brilliant.
So
That would change my job in significant amounts of ways.
now, based on your understanding of the ecosystem and the science behind it, do you think there is an underlying genomic or an epigenomic reason which might be contributing to their early aging?
There must be, and the research obviously is still very much lacking. The only thing that we know right now that contributes to premature early menopause, the majority of time, is for women who have a family history. So if their mother went into menopause early, and interestingly, my mom did go into menopause at 43. She didn't recognize that that was a thing. She was put on hormone therapy for 4 years, and then the Women's Health Initiative came out. And now at 48, she was taken off her hormone therapy, and now she has all the sequelae of not having been appropriately treated. So clearly that is something that I can't fix now, but had we had that information beforehand, she would have had a very different life today. So if there was some way for us to determine that, it would be a game changer.
Dr. Meenal, if I could bring you into the conversation, we're talking about innovations in precision health and the tools that support us in doing it. In your experience working and leading some of these cutting-edge labs and developing some of those labs, how do you think some of these innovations have actually facilitated the process of precision medicine?
Yes, so our lab in BioArrow, actually we are working on this epigenetic mechanism already where we are looking into DNA methylation, microRNA. So all these epigenetic factors are actually modifying the gene expression. So we are looking into transcriptomic and also the telomere length to see that how it is affecting or accelerating the aging process. So other than this, there are more innovations which we are planning to move ahead is senescence. So senescent cells are very good target to look into. So senolytics or senomorphics, those are the senotherapeutics which we can use to target these immune cells undergo senescence, and then again they are leading to the aging process. So if we can have some novel aging clock that is for immune longevity score, calculating it and then predicting those aging clock is definitely very good idea to move into the senescence. Other than this, mitochondrial dysfunction. So in our lab, we are looking into the mitochondrial dysfunction by seeing the level of NAD plus. So if NAD plus level is decreased, definitely it is accelerating the aging process. Cardiolipine in mitochondria is again leading to aging. So again, all those natural compounds, we can target these cardiolipines and all this mitochondrial dysfunction, we can fix it using these. So these are the lab innovations, which I think is
No, I think this is quite interesting.
But
to understand.
already we are doing in epigenetics where we are having aging clock.
Right.
And we are.
And I think in my conversations with you, I've heard you say that an integration of these biomarkers is more important rather than relying on one.
Yeah, that's very good point. So instead of going for single omic check, it's better to have omic MH, that is omics like whether it is genomic, proteomics, metabolomics, transcriptomic, all together with methylation, and then we are calculating the age. So that is omic MH. That will give you the comprehensive profiling and give you the early check compared to the single omic check. That's
John, if I could bring you into the conversation, I was listening into your presentation. You're talking about something here in the public sector, and then the innovation which is happening in the private sector. You know, Dr. Kapoor and BioArrow, they are a very good example of that. And then we have Dr. Premji, who is working with her patients in the public sector, and she is trying to do her bit. But then we have a patient who is still struggling, right? Why do you think the innovations in the private sector struggle to be adopted by the healthcare system?
Well, that's a huge question. And far be it from me to try and explain, especially the US system, even though there are some Americans in the room. But let me try and give you the context in which I think this works in the broad at least. Our system maintains the old order. We have a very long legacy system since the Second World War. That's run in the US at least, and it's mirrored around the rest of the world. Ultimately, at very top politically, by political will. Underneath that is there's a whole lot of legal and regulatory layers, underneath which is a fiscal layer, underneath which is an insurance layer, underneath which is a technology layer. So there are multiple stacked layers of legacy systems that have an interest in maintaining the system. The best example of that is a fee-for-service system, which is alive and well. We passed Obamacare in 2008, implemented in 2009. Here we are, 15 years later. We're still seeing 5 to 6% value-based care in the US system, which means 94% of the system is still fee-for-service. That's still heads in beds. So it's actually in the interests of the sick care system to maintain patients, unfortunately, for longer and stretch out the time because they're making money while they do it. So most of the current investment in that fiscal layer, and it's by private equity, it's by family office, it's by venture capital, it's about sustaining that system and tinkering at the edge. So fundamentally, that's where investment goes, because they know there are already reimbursement codes, they know there are pathways to profitability, to ROI for them in that system. If I jump to the wellness layer, if I can call it that, the prevention layer, the precision layer, all those things trying to make the system better, unfortunately, you have to disentangle everything above it. So you have to give incentive to everyone to switch, which means it's that Kodak moment, right? Kodak invented digital health. Why didn't they adopt it as a company? Because it cannibalized all of the income streams from their old business. And they died as a result. I think US healthcare in particular could well die as a result of not adopting, for example, full genomic sequencing for the entire population. This is probably something between $40 and $50 billion worth of investment, a drop in the ocean in a $5 trillion spend. So I think we've got to think about those aligned incentives and misaligned incentives and find our investment paths in that way and find individuals who line up with us in terms of wanting to change things for the better, particularly given the impetus we have with an aging population.
John, 30 seconds. You talked about investments and a couple of $1 trillion that we're looking at here.
Yeah.
Private companies who are innovating, they are looking for investments.
Yeah.
How can they stay away from those legacy investors who still have their roots in those, GEs or the insurance companies, so that any of the data, any of the innovation that they're developing is not influenced by those legacy investors?
Yeah. So again, simply, you've got to do your research. So I think there are venture companies that get this and are willing to disrupt other venture companies. Same is true in private equity. I think the family office sector is really interesting. I think they're more willing to go and take risk in terms of wellness side technologies that are a longer term play. It's family money. They're happy to make that multi-generational, but it takes longer to pay off. I think it's also true of sovereign wealth funds. There are sovereign wealth funds around the world that are willing to invest in preventive medicine generally. So I think I'll be doing my research. And I'll be taking my money there for strategic reasons, because it doesn't get gamed with exits out of pharmaceutical companies, for example, or to large hospital systems, which keep aggregating together and buying technologies, sometimes to shut them down so they can maintain the old system for longer.
Dr. Premji, 30 seconds. What can help people navigate the healthcare ecosystem better? Because we have to live with what we have, right? And until those innovations are adopted, we have to learn how to navigate the system and use the tools that are available. What can they do differently?
Are you talking specifically about women's health or in general?
In women's health, but in general, the larger, broader healthcare.
I think the most beautiful part about today's day and age is that information is at our fingertips, which is a huge blessing, but also can be a huge challenge as well, because it's very difficult for lay people to be able to determine what information you're being provided or told is based on sound evidence and literature versus somebody trying to make profit off of you. And so when, I recently attended a presentation from Science Up First, here in Canada, which is an event that was organized by the Canadian Association of Science Centers. And what they're really trying to do is help mitigate misinformation. And one thing I learned from that presentation is that when somebody tells you something, you always have to ask them, where did they hear that? What is the source? And if they can share that information with you, and then you can actually critically think about whether that information is adequate or not. And so now we are much more intelligent today than our parents were and our grandparents were, and we can critically really review information. And if you're ever unsure, then those are the three things that I would ask. Where did you hear that from? What is the source? And then go look at it yourself. That is the best that we
I
can
think
do
that's
right
very
now.
helpful. Yes. Well, if I had $1 for every question I have for this wonderful panel, I would have been a millionaire. But Harjeet, if I could just wrap up with you, what type of support you got from the ecosystem, from the community? And I know you have become a champion for this in the community yourself. How do you think the current system can be navigated for early diagnosis and preventing the experiences that you had?
I think there are a couple of things. First is early diagnosis, prevention. And I think being a young adult, we are not taken seriously. So that's the main thing which we need to talk about and, educate people that cancer can happen to any age. There's not certain age where we can have it. So that's one thing. And support groups. So obviously when I was fighting for support groups out here, I couldn't find someone with my own color or background. So because we are so underrepresented, in our community, that we don't find a lot of organizations to support South Asian, and we don't see a lot of South Asians talking about cancer because we have huge stigma, and plus there's education lacking too. Like I didn't have any knowledge about all those testing. If I had, I would have talked about, and now because I know that information, I talk about it more so that I can help other patients out there. But you don't have to be a cancer patient to know all those things.
Exactly.
So,
Dr. Kapoor, if we could wrap up the panel with a last comment from you. You have been innovating and doing things in the private sector on your own time. And there is a public sector which requires all of these innovations. How do you think things could be done differently to help facilitate the adoption of the technologies that you have developed into the healthcare ecosystem? I know you can't wrap it up in 30 seconds, but...
No, it's difficult, but I think people have to stand up. It's time. It's their life. I can only do so much. I can bring people together. I can create the amazing infrastructure and the amazing team together. So I think we are hitting close to the peak level. So now people, the audience have to stand up. It's their lives, their kids' life, their future. So if they don't stand up, they already know what has happened. And they're looking at the UK, we are going to the rabbit hole. So we need to now have other options and stand up.
Well, I guess that's all the time we have. I don't know how we are doing for time. But as I said, I had a whole bunch of questions lined up, but Dr. Mangat is making sure that we are on time. So is there time to open it up for a few questions from the audience?
Yes,
I know
but
some
not at the
hands.
moment. We will bring it right back to that.
Okay,
Good,
okay.
because we want to be on
Well,
time.
why don't you join me in thanking this wonderful panel? Thank you to all of you.